explained. If we think for gut-directed thrombolysis, we'll spend more than 24 hours. And after that, we do fasciotomy because of the thrombolysis drug. Thrombus removal also will take a long time for removal of thrombus and then creating AV fistula. And still, the compartmental syndrome will be present for a further duration. Anticoagulation alone or others? This is the question. This is the challenge. We have limb threatening, we don't have enough time, and we have to interfere urgently. So, as it is diagnosed as compartmental syndrome, and we urgently scheduled the lady for OR, and medial and lateral fasciotomy were done as you see. Of course, it is the skin is made not a complete incision, multiple islands on both medial and lateral side, with complete removal of opening of the fascia on medial and lateral aspects of the leg. The condition ran very good, and simple dressing for 10 days on a full anticoagulation therapy. After these 10 days, we made a skin graft, and this skin graft was completely taken, as you see. Now she has a nice leg and present all paresthesia and neurological complaint disappeared. She has to be complete anticoagulation for about 6 months. The outcome, the patient did well, successfully, could preserve the limb. Also, the lady regained the normal sensation and motor power a few hours after surgery. She was content for anticoagulation for 1 year. When we go through the literature, we found that the increased compartmental pressure following venous occlusion, following extensive venous thrombosis of the lower limb, is a rarely known process. Trauma and blood accumulation in these compartmental spaces of the leg may increase the traumatic incidence and increase the fluid accumulation using the anticoagulation therapy. Adelman and Hay reported few cases of muscle tears in the cuff region when they were fully anticoagulated, developing high compartmental pressure secondary to blood accumulation in the tissue spaces. So our take-home message, doctors should be aware of this unusual but troublesome complaint of DVT and have a low threshold for investigation, pain disappropriate to the expectations. When there are clear signs of acute compartmental syndrome is apparent, patient had to schedule for urgent fasciotomy, and this is important to preserve his limb. When DVT is a cause of acute compartmental syndrome, its appropriate management important, but the duration of anticoagulation. These are our references. Thank you.
Wonderful discussion. I think we can proceed directly to the first discussant, Dr. Jindal.
Hi. Thank you, Professor Ayman. It's a very, very interesting case, and it's a very common clinical scenario, what we face in the clinical system. So in our clinical experience, what we have observed, one of the two major risk factors, which should raise the suspicion when you see a patient is an extensive swelling, especially in the patients who are suffering from malignancy, and especially when the deep venous system and the superficial venous systems are involved. The question what comes, your patient came very late with the blisters and everything. which was a very clear-cut picture that this patient will require a fasciotomy. The question comes is when the patient comes a little earlier, then a differentiation that is it a severe venous congestion or is it a compartment syndrome sometimes clinically becomes very difficult. So the first, thing what we think, I think we should have is one is neurological symptoms, absent pulses, and if you have a calf tenderness, a severe calf tenderness which is unproportional, we can also do the compartmental pressures inside if you don't want to do the fasciotomy. And also, what we have observed is that movement of the leg, at the ankle flexion, at the ankle level, that really helps you that this patient will require an urgent fasciotomy. Now, question always comes is because, sometimes the patients are fit for mechanical thrombectomy, sometimes the patients are not fit for mechanical thrombectomy. Some patients, they do come with hemoptysis along with it. And then it's difficult to take these patients, but because of the mechanical thrombectomy devices nowadays, so we are able to take these patients up urgently into the theaters. Now, question comes: do the fasciotomy before the procedure, during, or after the procedure? That's another very important question to make. So, in our clinical practice, we always do the fasciotomy first, and before we do a thrombectomy. And the reason for that is because in the last 3 years, we had 2 patients. When we did the fasciotomies, all the muscles were non-viable, and actually we landed up with an above knee amputation in both these patients in last 3 years because of the delayed presentation. So I personally feel that we should do always a fasciotomy first, rather than this is why, because you can also check the viability of the muscles, which is difficult by any investigations, and early thrombectomies and of course anticoagulation is very important.
Thank you, Ravul. I totally agree.
Thank you so much for that. And Dr. Shaydakov, please.
Dear colleagues, dear friends, a little bit philosophy. It's very, very important. It's very interesting and helpful when you address such complex issues for angiology or vascular surgery. It's not only phlebology. It's a real angiology and vascular surgery. Unfortunately, I have recently become obsessed with treating superficial vein pathology. It's true. It's very helpful. It's very good. We improve our modern superficial phlebology, but much has been accomplished in this area. Radiofrequency, laser, glue technologies for extremely effective solution for varicose veins. But the situation with acute venous thrombosis is significantly more and more complex. Of course, preventive measures using modern medicines, reflected since comprehensive guidelines have reduced their incidence. However, when we actually encounter them in everyday clinical practice, we often give into the situation and opt for passive conservative tactics. Unfortunately, we have completely forgotten about the proactive surgical tactics. Meanwhile, timely and competent open thrombectomy can efficacy treat acute deep venous thrombosis, particularly in the iliofemoral segment. Let's recall the work of Boekloff and Tenny-Camerota. For 3 decades now, Niels Beckert has demonstrated the effectiveness of the catheter-based thrombolysis. And we know that modern catheter-based techniques also make it possible to treat severe venous thrombosis. Of course, all this requires painstaking work and high professionalism, and it's available only in specialized clinics. However, sometimes extremely severe forms of thrombosis are encountered, as Ayman demonstrated to us today. It's it's fantastic demonstration for me. Not a lot of patients, for about 15 or maybe a little bit more for my practice. Phlegmasia, cerulea dolens, blue phlegmasia in an extremely severe life-threatening form of acute deep vein thrombosis, characterized by complete disruption of venous outflow. this form requires emergency medical attention or to prevent gangrene, pulmonary embolism, and of course death. Indeed, this form of widespread thrombosis occurs in the setting of thrombophilia or malignant tumor, like this situation. At the onset of phlegmasia, thrombosis occurs in one of the large deep veins draining blood from the lower extremities. Within the first 2-3 days, the disease becomes generalized with thrombosis affecting several veins in the foot, leg, feet, and pelvis. On the 4th and 5th days of the disease, the microcirculation becomes involved in the pathological process. Venous circulation is primarily impaired, caused by thrombosis of venous and capillaries. As a result, hydrostatic pressure in the lymph increases and the liquid portion of the blood leaks from the vascular lumen into the interstitium. Swelling the fascial spaces causes compartment syndrome. Subsequently, secondary arterial ischemia occurs caused by compression of small peripheral arteries. Ulcerative necrotic defect like this in the distal part of the legs are gateway of the bacterial infection that quickly spread through the soft tissue and caused wet gangrene. So, it seems to me the main question is the question of the time. Ayman, when should a fasciotomy be performed? In the early stages of phlegmasia cerulea, when despite active anticoagulant therapy, we see an increase the pathological features, or when compartment syndrome appears. What do you think? What's your idea about it?
This is very good question. You have a very good point. If you have a patient admitted with phlegmasia dolens and we have enough time and not endangering the viability of the limb, I think the proper choice is to remove the thrombus either through chemical or mechanical. Really, I don't like catheter-directed thrombolysis. I prefer chemical. This is for me, it is the best scenario when I have a good time to prevent this luxury of time and save the limb. But in our case, I don't have this time window. Have to interfere in a hurry. You have a point, using thrombolysis or anticoagulation may increase the question. That's why we made soft tissue ultrasound before doing fasciotomy to see if there is fluid accumulation or trauma that may be increased due to anticoagulation. And this encouraged me to proceed for urgent fasciotomy.
Thank you, Ayman. Thanks again. I really enjoy analysis these kinds of difficult situations. It's one of unique and teach us how to adapt the modified standard treatment options. Thank you for a fantastic presentation.
Thank you. And I'd like to similarly thank you. I'd like to thank the discussants. Everybody has been very efficient with their presentations. So we have plenty of time, and I'm sure many questions can be generated. I have many myself, but one directly from the chat. Did you look for any other underlying conditions that may have predisposed to this? Maybe even after the fact. For example, antiphospholipid syndrome, if there wasn't a concern for malignancy, or why this was such a rapid, severe progression of phlegmasia.
Yeah, this is a very good question also. Really, we didn't check for thrombophilia screening before surgery, but as we started anticoagulation, we don't have perfect results, but we checked for antiphospholipid syndrome and it was negative. That's why we kept the lady for dietary anticoagulation, as we are sure it is not phospholipid syndrome.
Okay, wonderful. Now, from a technical aspect, I saw we do a lot. I'm a vascular surgeon, so I do a lot of fasciotomies for a variety of reasons. Arterial, much more rarely venous. Usually, and maybe it's my training or what we've been taught by our trauma surgeons, we make huge incisions. You made skip incisions. What are your thoughts in this particular situation about that? And maybe, certainly I can learn something from it. And how about closed versus open fasciotomies, where you perhaps close the skin? That was also a question from the audience.
Yes, this is very important technical questions. Uh, I, I have a little bit experience in doing fasciotomy as I am a military surgeon. We had many cases of trauma and some delayed cases, and we found that the long incision disturbed the viability of the muscle later on. So we made this island to keep some piece of intact skin, and we do closed fasciotomy up and down to be sure we open the spaces and we cut the fascia up and down clearly from both direction. It is for our practice, it is better than to have a very long incision. We found it is better for the outcome of the patient.
I mean, I think I already learned something very significant for how I'm going to manage my patients. Now, this is clearly an international audience. There are many tools that maybe some of us have at our disposal at large academic centers. There are 100, mechanical thrombectomy, percutaneous. But is there ever a role for, in these dire circumstances of phlegmasia, cerulea, or even alba dolens, for open venous thrombectomy? And I open that to the three of you. And is that something that you have come across in these situations? If you're doing a fasciotomy, is it worthwhile to do an open venous thrombectomy? And perhaps any tips and tricks from either you, Dr. Fakhry, or Dr. Jindal, or Dr. Shaydakov?
Yeah, regarding the fasciotomy, I'll just pass on one line. Like, we do get a huge embolic load we have, and of course, an acute embolic load, which is quite a lot. And so we do like 5 to 6 cases of fasciotomies a month at least. And
Wow.
so we all do 4 compartments, 2 5 centimeter incisions, and then we put in a subacute suture on that after that, and then we do the subcutaneously, we put in the blunt scissors under the fascia, and of course make sure that the lower end of the scissors, when it's on the muscle, don't injure the muscles, because then it bleeds. And you can do 4 compartments all open up with 5 centimeter incisions on both sides with subacutes, and that's a very standard practice, except in venous gangrene. So in venous, because the edema is too much, and then doing a fasciotomy of such small incisions is difficult. So there we do around 10 centimeters on both sides, but 2 incisions are more than enough to open up all the 4 compartments. We did one case approximately 4 years back during COVID times, and with an open thrombectomy, because we didn't had that devices available, and it was a nightmare situation. And I will recommend everybody to learn percutaneous systems, and because it is a very difficult scenarios, because it oozes a lot. And of course, first you remove the clots from the bottom end, you express with a bandage, all the clots comes in. Post-operative wound complications, because the edema is so much, it keeps on leaking, and nightmare. Percutaneous, we do like 7 to 8 cases a month now, and it's a very, very, very neat. So I think we should try to avoid open thrombectomy unless in a very dying situation where you don't have the access to all this, or it's better to refer it to the higher centers, the guys who have the availability.
Okay. The other question that comes up often is it's swollen, it's venous gangrene. What was your management with compression postoperatively? Dr. Fakhry, will start with you.
Great. After 1 month and after complete healing of taking of the graft, I put the lady for elastic stocking +1 for more than 1 year.
Mm-hmm. And how about Dr. Jindal or Dr. Shaydakov? Perhaps we can hear from you about, in these challenging cases, your management with compression postoperatively.
Yeah, because most of the stockings, they don't fit in all these patients. So as a standard practice, as soon as the wraps were available, so there are two things what we use if the patients can fit in. So we have got a customized wraps available here, and so we put in the thigh and the calf wraps. And if still the swelling is huge, so what we use the lymphedema bandages. It really works very nicely, because we remove the sheath for the percutaneous immediately, and then on table we put in a lighter version of the lymphedema bandage up to the upper thigh. Next morning we remove it. The swelling gets down by nearly 20-25%. It really works very well, because putting in a stockings in such frail skin with so much edema is not possible. I'm not talking about normal DVT patients. I'm not talking about all these difficult patients what we are discussing now. And once the swelling goes down in 5 to 7 days, and then we can put them on stockings.
Dr. Shaydakov, perhaps final comment, your management.
I fully agree with Ravul. The same situation in our clinic and in these situations. Yes.
Wonderful. And we have one more quick question we can perhaps address. What was your anticoagulation regimen? Did you continue therapeutic anticoagulation and then transition to aspirin or to a lower dose after a period of time? What was your anticoagulation regimen in this particular case?
Yes, for this case, as she was in a chemotherapy and she's an active stage, so I put her for therapeutic dose for the wax till she finished her chemotherapy procedure. She started to use after this 1 year and stopped chemotherapy. I put her for low dose anticoagulation for further 3 months. Then I stopped and kept her for aspirin and follow-up.
Well, I think that was a wonderful discussion. Thank you for that. And this is an incredibly challenging topic, and I know I learned a lot. I hope everyone had the opportunity to learn as much as I did. Wonderful presentation. I want to be mindful of everybody's time and also remind everyone of the next Vein and Lymphatic University Grand Rounds, February 25th. I think that's the wrong date because that's going backwards. the next Wednesday, 12 to 12:30. Same place, same time. Chronic venous disease as a cardiovascular risk factor and the role of venoactive medications. Dr. Manj Goel will be the guest host. Dr. Alejandro Gonzalez Ochoa will be the speaker, and there will be expert discussant commentary from Drs. Malay Patel and Dr. Liza Ochoa. Thank you, everybody, and I hope you all have a nice rest of the day. Take care.
Thank you.
Thank you. Thank you,
Thank
Coach.
you. Thank you. Bye-bye.
Bye.
Bye.
Bye.